Hello aspirant, in this particular module, we are going to see the bioequivalence study design and the protocol elements. So we will be seeing how to do the study design and how to prepare the critical protocol elements and how the protocol elements are being developed. Here is the GCP definition of protocol and protocol amendment. Protocol is a document that describes the objectives, design, methodology, statistical consideration, and organization of a clinical trial. The protocol usually also gives the background and rationale for the trial, but these could be provided in other protocol reference documents as well. Throughout the ICH GCP guideline, the term protocol refers to protocol and protocol amendment. What is a protocol amendment? A written description of a changes to or formal clarification of a protocol. So once we finalize the protocol and we are doing the study or before doing the study, if anything need to be changed or anything need to be clarified, it can be provided in the form of protocol amendment. So what are the study protocol elements? Important study protocol elements which has to be defined in the protocol development stage. So the first protocol element is the title and objective of the clinical study which is proposed. Then the study design. What is the study design? Whether it is randomized, whether non-randomized, two-way crossover or parallel design, something like that. The study design need to be defined. One treatment, two treatment, reference treatment involved or not, placebo involved. So all these things comes under the study design. Then the study population. So whether the study population is healthy or they are patients. So most of the bioequivalence and bioavailability studies are carried out in healthy human subjects, and sometimes it is in patients. Then the sample size, the number of study subjects. So some studies are carried out in 15 subjects, 16 subjects, 24 subjects. We do studies in 48 subjects, some studies more than 100 subjects. So this sample size need to be mentioned in the protocol. So this how this sample size are being calculated and what are the factors influencing the sample size we will be seeing in a different section of this particular module. Then the screening parameters. Once the study population has been decided, how you are going to screen for the fitness of the subjects into the study, that is going to be described with the protocol. Then the housing period. In case of bioequivalent studies, once the subject is inside the facility, how much time you are going to keep him inside the facility, what are all things you are going to do that need to be mentioned. Then the study treatments. In case of bioequivalent study, generally there will be a test product and the reference product. There can be two test product. There may be sometimes different kind of treatment. Treatment in the sense of fasting. One treatment can be administered in fasting and another treatment can be administered in fed. So something like that. So these and all comes under study treatments, how it is being administered, all those things. Then dosage administration, how you are administer the dosing, with water, with food, how much food, what is the calorie, how much ml of waters, all those things it has to be defined. Then the sampling time points. So once the drug is administered, in what are the time points you are going to collect the blood samples or the urine samples, what are the biological matrix is to be collected. What are the time points you are going to collect it, that has to be defined. Then volume of blood or volume of whatever the biological fluid need to be collected, need to be mentioned. For example, it is 4 ml, 3 ml, 5 ml, each time point, how much is going to collected, how much wastage will be there, what is the total volume of blood going to be collected, need to be mentioned in the protocol. Then once the sample is collected, then how the sample is being processed. So for example, blood is collected, you have to process the sample and store the sample. So for processing, you can separate the plasma from the blood or you can separate the serum from the blood. So how it has to be done, that procedure need to be defined in the protocol. Then how we are going to store, which temperature we are going to store, -20, -40, -80, all those things need to be mentioned. How within how much time you have to store. So all those things are important to be mentioned in the protocol. Then clinical safety measures, pre-study and post-study, both things, safety measures need to be mentioned. At what time point you are going to check the vitals of the subjects, ECG patal to be taken, what time point you will take, then any blood parameters, safety parameters need to be taken, at what time it will be taken. So all these things need to be mentioned. Then once this blood is collected, then stored, then all the subjects have been, safety has been established, the clinical phase is over, then it comes to the analytical phase where the analytical methodology is developed, then the sample will be analyzed for the blood concentration of the drug. Then Once the blood concentration of the drug is obtained with respect to time points, there will be pharmacokinetic analysis and the pharmacokinetic parameters will be established that need to be mentioned in the protocol. Then finally, the pharmacokinetic parameters will be analyzed for statistical evaluation for the bioequivalence, whether it is as per the bioequivalence criteria or not need to be established through statistical analysis. Finally, what is the bioequivalence criteria through statistical analysis need to be mentioned in the protocol. So generally the title of the bioequivalence study is looks like this, generally a open label. So there is no blinding is required for a typical bioequivalence studies. There are generally open label where the test product and the reference product will be administered to subjects by the physician. So the physician also, the investigator also knows that which subject have which treatment on the first period and the second period. Like that, volunteer also, subject also knows which treatment he is taking each which period. So it is not blinded, it is open label. So balanced. That means if you are taking 16 subjects, in the first period 8 will have test and 8 will have reference. In the second period, it will be vice versa. So it is a balanced approach. Then the randomized. So the number of subjects will be randomized. Which subject going to take test, which subject going to take reference. In the first period, it will be decided by the randomization. Then it will be either 2 treatment or 3 treatment, whatever the type of treatments, test product. If it is 1 test product, 1 reference product, it will be 2 treatment. Then the periods, number of periods. Generally, it is 2 period study. So 1 period you will have test, then the other period you will have reference or vice versa. So it will be 2 period or whatever 3 period it has to be mentioned. Then the sequence, whether the sequence means, for example, in 2 periods you will have first test T, then the followed by the second period it is R, means the sequence is TR. Then if it is some subjects will have first reference followed by the test, so that will be sequence called RT. So TR and RT is the 2 sequence. So generally it is called 2 sequence. Sometimes if it is 3 periods, there can be 3 sequence. So like that, the sequence will be decided. Then it will be single dose. Generally, bioequivalence studies are single dose studies. Sometimes multiple studies also being conducted. So that is has to be mentioned in the title. It is a crossover. So first period you are taking test, followed by the second period you are taking reference, so it is a crossover. Then the comparative oral bioavailability study. So we are comparing test and reference product in which population? Healthy adult human male subjects, then administered with applesauce under fasting conditions. So in case if you are administering, generally you are putting under fasting condition means it will be administered with water. Then if it is something has to be administered along with the fasting condition like applesauce, then you have to mention the applesauce. If it is under fed condition means after food it has to be taken means you have to mention it is fed condition. So this is how the title of the bioequivalence study is described. So the title has to say that the objective of the study is that to assess the bioequivalence, then the safety of the test product. Now the study designs, population and sample size. So the study designs, as I explained before, balanced, randomized, two-way crossover, two sequence, two period study, all those things need to be defined. Then the population, whether it is healthy males, females, mixed, like males and females are together taken, or special populations, or patients. So these need to be mentioned. Then the sample size. So as I told earlier, it has to be defined by the two important parameters based on the drug product characteristics. So the drug product may have the intrasubject variability. What is intrasubject variability? The intrasubject variability is, for example, I am taking the test product followed by the reference product. So how I am behaving differently for the test product as well as the reference product called intrasubject variability. And now myself taking the product and you are taking the product. There are two different individuals and how I am behaving and how you are behaving. So that is called intersubject variability. So now here it is very important. It is a crossover study. So the same subject will be behaving for test product as well as the reference products. So the difference of behavior between the products of the same subject called intrasubject variability. So for example, I am giving today test product Cmax of 300 nanogram per ml, and for after the during the second period for the reference product I am giving 350 nanogram per ml. So T by R will be 300 divided by 350. So the difference, the variations like this. So each and every subject have the intersubject variability. So that accumulated variability will be defining the sample size. If the variability is more, the sample size will be more. If the variability is less, the sample size will be less. Like that formulation ratio. For example, I am giving Cmax of, for example, 100, and somebody is giving for the same person, I am giving for the reference product 90 is the Cmax. So the T by R will be 100 by 90. That means it will be how much? 110%. 100 by 90 will be 110% or more. It is more than 100%. So the ratio will be more. In case of it is reverse, if it is 90 by 100, the 90% will be the ratio. So here the ratio will be should be as close as possible. If it is 95 to 105 is the ideal for the formulation. So if it is less than 95 or more than 110, then the sample size also will increase. So generally the ratio should be as close as possible to the 100, and then the inter-subject variability is critical for the sample size calculation. There are published sample size tabulations based on expected TVR ratios, so based on which you can select the sample size and the inter-subject variability. So when we select the subjects for the clinical phase of the study, there are several screening parameters we need to consider. So to prove them healthy subjects. So when we take the healthy subjects, to prove them healthy, we need to do a lot of evaluations, including hematology, biochemistry, urine examinations, drugs of abuse test, alcohol breath test, and other special investigation, if any. Then it comes to the housing period, how much time you are going to retain the subjects. This will be defined, depends on the blood draw time points. If it is you are taking continuously blood samples for 48 hours, you need to house the subjects for 48 hours post administration of the drug product. And generally before administration of the drug product, you have to keep them for 12 hours minimum to maintain the conditions, fasting conditions, and other recommended conditions for the study. So these screening parameters includes your BMI. Sometimes the BMI is restricted due to control, have the control on the physiological variations of the drug product. The BMI will be taken care, the weight, body weight will be taken care, and sometimes the populations, it will be healthy human adult male subjects, or sometimes females will be selected for specific products like corticosteroids and hormones. So that these and all will be defined during the screening parameters. Now the study treatments. Thus, what are the study treatments going to be involved in the study, bioequivalence study? So there always there will be test product which has to be used for the assessment of bioequivalence. Then there will be a reference product which is already a marketed product against which the test product is tested. Then the dose selections, which is very important, which dose you are there can be a multiple strengths for the test product. So you have to select the dose for the bioequivalence study, which generally the highest dose. Then placebo use used or not. In case of bioequivalence studies, there is no use of placebo because it is a open label study always. Then the products need to be manufactured under GMP. Then certificate of analysis of the product, which is critical because the assay of the products, test and reference product has to be close to each other. It has to be more than 95% for the test as well as reference to make sure that you expect the bioequivalence provided the in vitro properties or the product properties are as close as possible. Then you have to mention the administrative procedures of the drug product, like whether it is fasting, fed, or multiple dose study, whether you are administering with applesauce or you are administering the water or food, that has to be clearly detailed in the protocol. The dose selection. So the dose selection of the pharmaceutical products is based on the safety of the dose, what we are going to administer. So for example, each and every product have multiple strengths, and generally the bioequivalence studies are recommended to use the highest dose. Since we are doing only single dose, the safety of the product is ensured, and the highest dose can be used for the bioequivalence studies. But some cases, the highest dose, even single dose, can create a lot of side effects, adverse events. So in that case, the lowest dose or the middle dose can be recommended for the bioequivalence study. Here are some of the examples has been recommended by US FDA for the bioequivalence studies. For example, topiramate tablets, the lowest strength is recommended 25 mg against the highest strength 200 mg. Then the glimepiride tablets 1% because it has the potential anti-diabetic activity. That means the insulin levels or sugar levels go so low, the highest dose can be potential to give side effects. Then the olanzapine tablets, the middle dose 5 mg has been taken. Risperidone tablets, lamotrigine tablets. There are several case of examples where you can use the middle or lower dose for the bioequivalence studies due to safety reasons. But generally, the highest dose is recommended for the BE study. Now, the most critical, important aspect of the bioequivalence study is the selection of sampling time points and sample processing. The selection, first we will see the selection of sampling time points. So how it is being selected. So generally, to select the time points, there are two important pharmacokinetic parameters need to be studied through literature. That is one Tmax and other one is the half-life. So the Tmax and Toff defines the sampling time points generally. So for example, if you have a Tmax of 45 minutes, it's a fast absorbing drug. So you have a Tmax of 45 minutes, then you have to have more time points around the Tmax, because the Tmax, by the Tmax, the absorption, most of the absorption gets completed. So you are characterizing the absorption property of the pharmacokinetics. Hence, it is important to characterize the absorption phase. Hence, you need these more time points around the Tmax. For example, 45 minutes, then you must be having every 10 or 15 minutes, you have one sampling point in and around Tmax. So for 45 minutes Tmax, you will have 10 minutes, 20 minutes, 30 minutes, 40 minutes, 50 minutes, 60 minutes, then every 15 minutes further 1.25 hours, then 1.5 hours, like that. You will have around 7 to 8 time points around before and after Tmax will give you a proper characterization of the absorption phase. So this is how the sampling time points around the Tmax is designed. Then you have the half-life to characterize how long you are going to draw the blood samples. So generally it is 3 to 5 half-lives. For short half-life drugs, you can go for up to 5 half-lives, and long half-life drugs you can go up to 3 half-lives. So if the half-life is 6 hours, then I can go up to 16 to 24 hours blood draw, the duration, total duration. So if it is half-life is more than 12 hours or 16 hours or 24 hours, you can go up to 5 days or 6 days. So when it comes to the long half-life drugs, how you will design? So the you will have around the Tmax frequent sampling time points to characterize the absorption phase. Then to characterize the distribution and elimination phase, you can have a gap of long hours between the samples. For example, for a drug, you have a Tmax of 2 hours. So around 2 hours, before the 2 hours, around every half an hour, you can have the sampling time points. After 2 hours also, you can every half an hour you can have the sampling time points to characterize the absorption phase. Then the distribution phase and the elimination phase is prolonged for long half-life drugs. So you after 4 or 5 hours or 6 hours, you can go for 12 hours, 18 hours, 24 hours, 36, then 48, 72, 96 hours, like that. You can do the blood draw to characterize the distribution and elimination phase. So the elimination phase needs to be characterized properly so that your elimination parameters half-life and elimination rate constant will be characterized properly. If you are not able to characterize the elimination phase, that means you are not selecting a time point where the baseline is achieved. At the end of the blood sampling collection time point, your blood level has to reach the baseline. That's how you can characterize the elimination properly. So this is how both half-life and Tmax are critical for the selection of time points. In case of short half-life drugs, you can have the in and around the Tmax, you can have several time points. Then you can have 3 to 4 time points which can characterize the absorption as well as the elimination phase. So this is how the sampling time points are designed, and there should be minimum one time point before the Cmax. That is what very clearly defined. Your first time point after the administration cannot be a Cmax time point. That is very important. At least one time point before the Cmax you should have to show that the absorption phase is clearly characterized. That means one non-Cmax time point before the Cmax should be available. Then you collect the pre-dose samples to show that you don't have any drug in the blood before administration of the same drug for which bioequivalence studies is carried out. The baseline characterization is very important for non-existent of drug before the dosage form administration, and in case of endogenous drugs like hormones where you have already present, for example, thyroid and some kind of estrogen, some kind of hormones, you already have the concentration of this hormone in the blood. So the baseline characterization has to be important. There are several blood samples before the drug administration will be collected to get average out of a concentration which is a baseline concentration which can be subtracted from the post administration of the drug concentrations. We have sufficiently explained the selection of sampling time points and how we process the samples now, we will see. So the processing of the samples, once you collected in particular time points, you have to process through the centrifugation at particular temperature to separate the plasma or the serum. Then you have to store the samples in the deep freezer at a particular temperature. This is the sample processing procedure has to be defined. Then it is also important what kind of anticoagulant you are going to use in the vacuotiners during the collection of blood samples, how you collect the blood draw, whether it is a direct vein puncture or it is a continuous blood draw using a cannula. So all these things, procedures need to be clearly mentioned in the protocol. And then the blood collections, if you are doing every 12 hours or 24 hours, the subjects need not be in the housing area. So it can be collected as a ambulatory collections where the subject will come on the particular time and give the samples for the blood draw. So the clinical safety measures. The clinical safety measures need to be clearly defined in the protocol. So pre-study, what are the safety parameters? During the study, what are the safety parameters? Post-study, what are the safety parameters? So the pre-study safety parameters, like generally the screening parameters are the pre-study safety parameters, where those who are not eligible or those who are having any illness, we should not take them for the study by screening the patients or the subjects. Then during the study, post administration of the drug product, we have to see, monitor the vitals. We have to, if required, there has to be ECG. All those things need to be taken. Then finally, the post study, some of the blood samples will be collected for the laboratory evaluations like biochemistry and hematology to whether to see that they are in the same level or anything is elevated. So these are the general safety measures taken during the biochemical studies, and it has to be clearly defined in the protocol. Also, in for the safety measures, there will be medical officers, intensive care units, ambulance, hospital collaborations, medical experts in case if it is required. These all need to be arranged, but these are not necessarily to be mentioned in the protocol. Then comes to the important parameter, which is the washout period. So when we do the crossover studies, for example, I am the subject, I am going to take the reference product, I am going to take the test product on two different occasions on two periods. So first I will take one product, then I have to wait the what product I have taken has to be completely eliminated from my body. Then I will go for the administration of the second product. So the time taken for complete elimination of the drug product from my body is called washout period. So generally this washout period is defined by the half-life of the drug. It is generally 5 to 10 half-lives. If it is a short half-life drugs, you can consider 5 to 10 half-lives, maximum 10 half-lives also you can take. So short half-life drugs of 2 to 3 hours, you can consider 3 days as the maximum washout period. If it is 12 hours, it's 7 days of the washout period. If it is more than 24 hours, you can consider 15 days or 21 days is the washout period. Some drugs which takes very long time to eliminate from the body, for which you can do the parallel study design where one set of subjects, one group of subjects can take test product, another group of subjects can take the reference product randomly. So here there is no intra-subject variability, or the same subject is not exposed to both the products. So this is called a parallel study designs. And sometimes you can do truncated AUC approach where you can stop the time blood collections at 72 hours, and up to 72 hours you can characterize the drug absorption profile and elimination profile. You can have a pharmacokinetic profile up to 72 hours. Then there won't be any elimination parameters characterized in the truncated AUC approach. So here are some of the examples of washout period for some specific drugs like cefuroxime acetate. The half-life is very short, so 3 days is the washout period. Fexofenadine tablets, the T-half is moderate, 15 hours, so at least 7 days is the washout period. In case of fluoxetine tablets, the half-life is 190 hours. The analyte is norfluoxetine, which is retained in the body for so long time. So here, at least 75 days of washout period is required. But in this case, you can approach for parallel design studies, or you can do the truncated approach. But still, parallel design is the most appropriate. You cannot wait for 75 days. If it is low variable, you can go for the parallel design studies. Now comes to the analytical methodology. So you have to mention briefly about the analytical methodology which is need to be followed for the bioequivalence study. So the first comes is the what you are going to analyze, whether it is a drug or metabolite or both. That has to be clearly defined. And also you have to define metabolite data, whether it is supported data or it will be used for the bioequivalence conclusion. So that is first and foremost is the what we are going to analyze, that has to be clearly defined, and then briefly about the which method you are going to adopt, whether it is LCMS technique or HPLC technique, that has to be mentioned in the protocol. And if required, you can give a brief methodology like which extraction procedure, column details, and the chromatographic conditions. So all those things you can, if required, you can mention. Otherwise also not a problem, because these details are separately given in the detailed bioanalytical report along with the study report. Then comes to the pharmacokinetic parameters has to be defined for the bioequivalence study protocol. So the primary pharmacokinetic parameters generally Cmax and AUC. AUC sometimes up to the last time point collection also defined, and the 0 to infinity, the what you call extrapolated AUC also can be added to the primary pharmacokinetic parameters. So Cmax and AUC as the primary pharmacokinetic parameters based on which the bioequivalence will be concluded has to be clearly defined. In case of steady state studies, there will be steady state parameters like Cmax SS, C min SS, AUC steady state, and C tau SS are the parameters are clearly defined in the protocol. Then the secondary parameters, elimination parameters include Tmax, elimination parameters like T of and elimination rate constant, and absorption parameters like Tmax has to be defined. These are not used to conclude the bioequivalence. And which method you are going to adopt to calculate these parameters also need to be defined, whether it is a software based or the manual based, winnoling are being used or not, has to be defined in the protocol. We have mentioned about the pharmacokinetic parameters in the protocol. Now the parameters, since we are collecting across the subjects, many subjects, so it has to be summarized in a proper manner. So summary statistics like mean, standard deviation, coefficient of variation, minimum, median, maximum. So all those information has to be tabulated in the form of summary statistics for each and every parameter like Cmax, AUC, Tmax, etc. Then the geometric mean of the test and reference product for Cmax, AUC has to be given. Geometric mean ratio will be given. Then the intra-subject CV has to be reported. Then the power of the study, whether the sample size is selected is sufficient to conclude the bioequivalence, that has to be denoted by the power. It has to be always more than 80% for the bioequivalence study. So that also has to be calculated and reported. And the 90% confidence interval, that is the important criteria for the conclusion of bioequivalence. So when the 90% confidence interval for the Cmax and AUC will be calculated, that is also will be reported. And then the methodology adopted for the calculation of these parameters, whether it is software based or manual based, that also need to be mentioned in the protocol. Finally, the bioequivalence criteria need to be mentioned, then based on which criteria you are going to conclude the bioequivalence between the test and reference product. So already we have told about the primary pharmacokinetic parameters, which is Cmax and AUC, for which 90% confidence interval will be calculated. So generally the 90% confidence interval for the Cmax and AUC should be within the limit of 80 to 125%. So the topper side, higher side, it is 125 because of the log conversion. Generally, it is plus or minus 20%. So since we are converting to logarithmic scale, it is 125% on the higher side. And for the US FDA, parent drug should be evaluated for the bioequivalence, and metabolite data can be given as a supportive data. For Europe, both parent and active metabolite sometimes considered for the bioequivalence, and in most of the cases, metabolite need not to be measured, even though it is active metabolite, it need not to be measured. For narrow therapeutic index, it is narrowed down the bioequivalence criteria. Cmax narrowed down to 90 to 110%. For some drugs, Cmax, AUC both are narrowed down. So in some countries like South Africa, the Cmax criteria for bioequivalence conclusion is 75 to 133%. And in case of a highly variable drug, based on the variability, you can extend the acceptance criteria beyond 80 to 125 based on the statistical justification. So now in this module, we have come to an end about the bioequivalence study design and also the important protocol elements, where how the elements are defined in the protocol, how we have to present in the protocol, what are the elements need to be captured in the protocol, we have discussed. And going forward, we will be discussing about the flow of the events in the bioequivalence study in a detailed manner for each and every phase. Thank you.